You are live now, sir.
Good evening, all. Welcome to another episode of Dry Eye CliniX, and this is the fifth one in our series. And we are lucky to have Dr. Deepa, who is going to speak on a very important topic. In everybody does a cataract surgery, and what happens to the surface, and how the patient presents, and what to do about that. And we are lucky to have our alumni from RT Center and a very popular man. You must have seen him doing live surgery, taking lecture in any one of the conference, Dr. Srini from Kerala. And I request Dr. Anu Malik to introduce our speaker and our chairperson and our welcome our panelists for today. And then we'll move on to the talk. Dr. Anu. Dr. Anu, you're muted. Dr. Anu, please introduce the speaker and chairperson for
Okay,
today
sir.
and panelist.
Good evening, everyone. Welcome to fifth episode of Dry Eye CliniX of DOS Super Tuesday, an initiative of Delhi Ophthalmological Society, with special thanks to our President, Dr. Rohit Saxena, sir, and Secretary, Dr. Praful Kumar Maharana. Our topic for today's webinar is Navigating Dry Eye Syndrome in Post-Operative Care. So dry eye is an often underestimated challenge that many patients have to face in post-operative period. So today we'll be diving into the discussion on this topic, and I extend my warm welcome to our chairperson for today, Dr. E. Srini, sir. Sir is the Chief Medical Director and Surgeon at Comtrust Eye Hospital, and he has been the former chairperson scientific committee at Kerala Society of Ophthalmic Surgeons, and he's also the member managing committee of AIOS. It's my pleasure to welcome Dr. Deepa Gupta, our speaker for today's webinar, who will be sharing her valuable insights. Dr. Deepa Gupta is a consultant cataract, cornea, and refractive services at Lal 2020 Eye Care Hospital. She has vast experience in all kinds of refractive surgery and cataract surgery. She is performing all kinds of lamellar transplants, and she has many publications and presentations to her credit. We welcome you, Dr. Deepa, to our virtual stage. Now we can start sharing your presentation. We are also thrilled to have a distinguished panelist and discussants for today's webinar, which promises to be an engaging session. Ma'am, you can share your presentation.
We
Thanks
have
a lot.
Dr. Ma'am, please.
Yeah. I hope everyone can see the presentation.
No, I
Not
think
yet, ma'am.
we'll
Not
have to
yet.
start share the screen. In the meantime, we have Dr. Parul Gupta from PGI Chandigarh and Dr. Gunjan, and they are always here to help us in our all the dry eye clinics webinars. Thank you, Dr. Parul and Dr. Gunjan.
Thank you, Dr. Praful.
शरीक एक बार देखो पीपीटी.
Ma'am, you have to share, click on the share button and then.
Yeah.
Yes.
Is it visible now?
Yes.
Yeah. Thanks a lot for your warm welcome, Dr. Anu, and it's always a pleasure presenting in such a platform. And thanks to Dr. Srini also and Praful especially for inviting me here. So I'll be speaking on dry eye and how to navigate and during our surgical practice, and what are the common symptoms and how to evaluate the same, including the management. So dry eye disease, I would say, is nothing short of a pandemic or an endemic now, since especially in countries like India, which has a large economy and a large aging population, so the prevalence of disease is more common, and it is getting more commoner day by day. So coming to the dry-eyed disease, it is nothing but a multifactorial disease of tear dysfunction and ocular surface, which is associated with multiple pathogenic mechanisms. And out of these causative factors, which you can see in the outer circle, our focus would be mainly on the ocular surgery, which is mainly the cataract and the refractive surgery. As you can see, it is nothing but a vicious cycle, which includes tear film instability, inflammation, apoptosis, and mucous membrane damage, which accompanied with MGD leads to the symptoms and severe symptoms of the dry eye. As you know, the surgeries which are most commonly performed are the cataract and refractive surgeries, and they give, along with the improved quality of life that they promise and give, there is also a flip side in which it comes with a complication of a dry eye, which is well neglected and a very important symptom and a sign, and a per se it's a disease which gives rise to blurred vision, dryness, and foreign body sensation to the patients. It can persist from 3 months up to a year or probably more, and often the patients can blame the surgery and especially the surgeon for the same. We have had patients, in fact, I have had patients saying that now, no, I want to get the surgery done by other doctor, the other eye, because this time I had a lot of, I'm still having watering and I'm having pain, so I want to go to another doctor. And while the surgery was perfect and the vision was also same. Vision was also perfect, but the patient are not happy. So a lot of times, dry eye is the main implicating factor. The most common problem, like most common symptom of the dry eye is sensitivity of light and blurred vision. And it can also present as itching, foreign body sensation, dryness, stinging, burning, and even pain. Coming to the cataract surgery and iatrogenic dry eyes. Most common performed cataract surgeries are phacoemulsification, either with either MICS or with femtosecond laser. So the prevalence is almost 30% of the patients after dry eye, after surgery, they complain of symptoms of the dry eyes. Not only it can cause dry eye, but it can exacerbate the pre-existing dry eye disease. So the correlation has been well documented in between the both. So the severity is maximum at 7 days post after cataract surgery, and it may persist for months. And in further studies, it has been seen that the symptoms and the disease eventually improves at 1 month and 3 months post-operatively. And after 3 months, you can see only 9% of the patients have persistent dry eyes. Now coming to the pathogenesis. So the most common, as we already discussed, are phacoemulsification, in which the prevalence is around about 30%. So it includes basically intraoperative irrigation of the tear film and use of topical anesthesia, which contributes to the dryness. In femtosecond laser, the direct contact of the suction cup to the ocular surface and prolonged exposure time affects tear film and ocular surface function. So the multiple pathways, they lead to dryness pathogenesis, which includes the preoperative factors like age, medical background, previous or unknown MGD and DED, usage of drops, and surgical prophylaxis. Intraoperative factors like speculum, surgical time, light exposure, suction ring, irrigation corneal sutures, and post-operative use of preserved eye drops, antibiotics, and NSAIDs, they all lead to some amount of ocular surface trauma, which leads to dry eye disease. Also, the incisional nerve damage further causes disruption of the neural feedback, which reduces tear film production from the lacrimal gland, which leads to tear film hyperosmolarity and inflammation, which further causes aggravation of the dry eye. So we have also seen the very important sign, which is the tear film meniscus height. It gets narrowed after the cataract surgery. Also, there is seen which is altered meibomian gland dysfunction, which commonly happens post cataract surgery. Lot of drugs have both systemic as well as ophthalmic drugs have been implicated in the mechanism in the pathogenesis. So most commonly are these listed, and even the systemic drugs like antidepressants, diuretics, etc., have been implicated. Now coming to the diagnosis and the management. So the most commonly performed tests and the effective ones are the lid margin assessment, fluorescein staining of the cornea, tail film breakup time, and Sherman's test, which they have stood the test of time and must be performed before taking up the patient for cataract surgery. Coming to the prevention of dry eye disease. So preoperative is a good assessment. Intraoperative limiting incisional damage, limiting drop exposure, limiting repeat drying irrigation, limiting phototoxicity, and surgical trauma. They go in a long way and helps reduce the postoperative dry eyes. Postoperative measures are primarily the treatment, which I'll be discussing in detail. Along with the drugs and the prevention factors, education, environmental modification, lifestyle modification, dietary changes, medication reviewing, lid hygiene and tear supplementation, they play a major role in prevention of the dry eye disease. Now coming to the next subset of the surgery, which is the refractive surgery. As we all know, there are 4 common types of refractive error. And the prevalence of myopia is as high as 28.3% of the global population, which makes refractive surgery is one of the most common surgeries performed all over the world. So the criteria is myopia up to 12 diopters, hyperopia up to 6 diopters, and the vision should be stable, pupil and corneal thickness should be adequate. The absolute contraindications for the LASIK are presence of any corneal abnormalities, presence of severe dry eyes, pregnancy, lactation, any uncontrolled, any systemic or ophthalmic uncontrolled disease, and unrealistic patient expectation. The patient should not be taken up for the surgery. There are various types of refractive surgeries which are available, which we all know about. So presenting a typical clinical scenario, patient comes after 6 months, which is he's not happy with the vision despite being 20/20. They say that the eyes get tired while working on the computer. They can't see the monitor for a long time, or there is glare in night driving, and the vision improves with lubricant, but only for some time. And the eyes are, consistently they're hurting, and the drops don't help. Sometimes there is prickiness, and many times they say they are persistently they are red. So these are all nothing but the symptoms of dry eyes. So it is one of the most common complications of LASIK, which affects approximately 50% of the patients at 1 week, 40% at 1 month, and 20 to 40% at 6 months. Although it is usually corrective, but still some patients can have a negative influence over their satisfaction. Also, approximately 20% of the patients experience dryness, which became worse than preoperative dryness, because most of them are working on computers. So they already have a little bit of pre-existing dryness or a MGT, which kind of worsens after LASIK. So it becomes very uncomfortable for them. Also, 20% of the cases with dry eye persist longer than 6 months after surgery. So these patients can be, who keep coming back to your clinic again and again. So overall, the risk factors are gender, women, and presence of a pre-existing dry eye disease, Asian origin, any comorbidities, ablation depth, suction time in surgery, position of the hinge, and the patients who require more refractive correction. These are all the risk factors. Now coming to the ocular surface changes after the refractive eye surgery. So after LASIK, as due to the nerve plexus damage, the patients develop a relatively hypoesthetic cornea, and the corneal sensitivity usually improves and ranges and approach preoperative range of sensitivity by 6 to 12 months. You can see in confocal microscope, there is corneal denervation, and almost 100% of the subbasal nerve fiber density is reduced, and for up to 6 months of post-LASIK, and it may not return to the preoperative levels by 2 to 5 years. in confocal microscopy studies. There is this patient who had a line which is known as LASIK-induced neurotrophic epitheliopathy staining. So this patient is actually one of our clinical patients. He developed it happens due to the hypoesthetic cornea, and it leads to vision blurring and pain, which improves later on with intensive lubricants. Conjunctival changes mainly occur in the form of because of loss of goblet cells immediately post-operatively, with because of the reduction of goblet cell mucin leading to tear film instability. Tear changes, they occur in form of increase in osmolarity, increase in inflammatory markers, and also reduce in ascorbic acid levels. Accompanied with decreased blink rate, the overall tear film stability becomes less. As I've already discussed, there is nerve damage during the subbasal plexus damage during both LASIK as well as SMILE. Corneal sensations are reduced, and tear films there is reduced tear secretion and tear film stability. So, in order to summarize, in post-LASIK cases, there is disruption of intracorneal nerves, damage of goblet cells, and altered corneal shape. Excuse me. So, all these can lead to various interplay of the various things like tear secretion, tear stability. They can affect ocular surface damage, which leads to dry eye symptoms. So nothing, there's no single factor, but yes, the interplay of various factors which results in the dry eye. So again, the preoperative evaluation should be done with Shermer's TBUT, meibography, staining, etc., OSDI, and the severity should be graded as well as the type should be identified in order to further treat. So there are new modalities like interferometry, confocal microscopy, and inflammatory biomarkers measurement, which can further add on to our basic tests. So there are various systems which are dry eye diagnostic systems which are readily available these days. It can be incorporated into slit lamps, and they help in identifying as well as grading and subcategorization of the dry eye. So basically, it has inbuilt OSDI scoring, non-invasive tear meniscus height, non-invasive breakup time, fluorescein breakup time, meibomian gland function evaluation. You can see the beautiful picture of the glands. Then lipid layer thickness by interferometry, assessment of the hyperemia, and magnified and a very accurate view of eyelid margin and assessment and corneal staining. So they give a printout. It is also done in LipiScan and various other modalities. Various other companies, they have come up with their own softwares to make our life simple. And it kinds of gives this printout and with which we can assess. Now, finally, coming to the management of dry eye in ocular surgery patient. So this is the same picture which I had shown in the beginning. So at various pathogenic mechanisms, at various levels, we can intervene. The first and foremost is to identify where we have to, where the problem is. And according to that, we can, supplement the tear or conserve the tears, stimulate the tears, or we can use lipid stimulation if there is little tear film instability. We can use IPL or antioxidants or anti-inflammatory drugs to reduce the inflammation. Now coming to the management approach. So as we all know, the mainstay is using the artificial tears. So if we see that the requirement of artificial tears is less than 4 times a day, then we can use any preserved or a transiently preserved eye drops. If we feel that it is more than 4 times a day, then we should prefer a non-preservative eye drop, non-preservative artificial tears. Along with it, we have to treat any lid margin disease associated with it with lid scrubs or an ointment or compresses or doxycycline maybe. Then further on, if it doesn't improve, then nutritional supplements can be added. Also topical anti-inflammatory drugs, especially cyclosporin A in this concentration and recently 0.9% concentration, that can also be added. And steroids can be added if there is inflammation, and then they can be tapered off. Strategies. Then coming to severe refractory dry eye, in case it's very, very rare, but in case it develops, we can use punctal plugs or autologous serum or an oral doxycycline. So same thing, preserve artificial tears up to 4 drops per day, rest preservative free of artificial tears, then steroids, and to improve this inflammation. So coming to the artificial tears, they are the primary treatment for the post-keratofractive dry eye. So the preservative-free tears are usually recommended, but even the other ones, they work very well. Almost 86% of the patients, they report symptom relief after dry eye. So that is a very good advantage. Now, coming to the artificial tears, basically they contain 3 kind of components. First is the active ingredient, which is also called as demulcent. It is the FDA-approved water-soluble polymer, which helps protect and lubricate mucous membrane surfaces and relieve the dryness and irritation. The various types are available, like cellulose derivatives. CMC 1%, it is most widely used, like Flogel, Refrigel, etc. HPMC, methyl cellulose, dextran 70, gelatin. Then comes the polyols, which is PEG, like polyethylene glycol, glycerine. They can be added to it. Along with polyols are usually used with polymers, like polyvinyl alcohol. So PEG and PEG PG is a very, very commonly prescribed, like which is present in your Cysteine Ultra and Flogel Ultra, etc. Also povidone. Now comes excipients. Excipients are also biological active ingredients, but they are added as inactive in order to avoid the FDA trials. So they are also similar to the active ingredients, but they are written it as inactive so that they don't have to undergo the FDA trials. So first and foremost are the protectants, which are trehalose, examples of which are, recently it has become very popular. Trehalose, erythritol, and levocatine. They prevent basically the osmolar stress on the tear film. Then comes the humectants. The most common and the most popular in humectants is sodium hyaluronate. They are basically hygroscopic agents which prevent water retention. They are very popular and effective due to the mucin binding capacity and increased retention time. Then comes your hydroxypropyl guar gum. It is basically present in Cysteine kind of Cysteine products. And last are oils, which are used to protect and preserve the lipid layer. Coming on to the preservatives. So there are 3 components: demulcents, excipients, and last one is the preservative. So purite, polycotonium, and sodium perborate with the stabilized oxychlorocomplex are the most commonly used, and BAC also. So they are more safer than using BAC, which is now relatively less used, and it is more supposed to be more surface toxic. Hence, I would like to conclude my talk saying that dry eye syndrome in post-operative cases, it is well-established cause for patient discomfort and dissatisfaction. It needs adequate diagnosis and management strategy, and it has to be customized as per the patient. Artificial tears are the mainstay, and they are sufficient in more than 80% of the patients. Lid hygiene, treatment of MGD, and lifestyle modification, they help and they go a long way in supportive care. Refractive surgery should be avoided in severe dry eye patients, and cataract should be done in a very cautiously manner, informing the patients and about the treatment and severity. Thanks a lot for your patient hearing.
Thank you so much, ma'am.
Yeah, but excellent, comprehensive talk, Dr. Deepa. See,
Thank you, sir.
if you see, it's sort of a 6/6 disease. So you get a patient who is not 6/6 on the first post-op day, I mean, they are the patients who don't actually complain that they have dry. You have a patient with 6/6, you can expect. I mean, they have something more to think about. And but jokes apart, this is definitely a problem that all surgeons do face. See how you've talked about the management. You talked about the preoperative assessment and all. So how significant is meibomian gland dysfunction as a cause for dry eye disease? Because sometimes, I mean, you always check the lids before you post the patient for surgery, and occasionally you find frank meibomian dysfunction. I mean, you said in the presentation also, post cataract surgery, it can be aggravated. So how do you actually manage the meibomian gland dysfunction preoperatively? And if the patient has a meibomian gland dysfunction, when do you actually take up the patient for cataract surgery post-treatment?
Sir, what I would like to say is that most commonly we diagnose MGD post-operatively. And in fact, because of persistent use of drops, sometimes if they actually get the MGD because of that, because of poor lid hygiene, and they're not able to take care of, and they're just putting the drops. So sometimes due to that also they get MGD. In patients in whom there is no MGD prior to the surgery, it can develop later on. So the most common treatment which I give is usually hot fomentation, and we have to tell them properly that how to do the lid massage after fermentation, and how to do a lid massage, and then how to clean the secretion within. But it is extremely common. It is very, very common. It is more common than than expected, actually. I mean, that's what we've seen.
And
Preoperatively also, yes, a lot of when we are doing LASIK, then whenever we are washing the flap and the secretions, they just keep flowing under the flap, and we are just cleaning so many times. That also happens. So
you have that
then we
oily
realize, oh, this
coming. Yeah, and
oily secretions, there are so much.
Yeah, and you use doxycycline for the management of meibomian gland dysfunction. I mean, what's your treatment protocol for meibomian? See, I mean, it's easier. See, you talked about hot fomentation. Problem is, I mean, I see that frank meibomian gland dysfunction 1 week post-op, and it's you find it difficult to tell the patient to do hot fomentation. You don't know how they're going to do it, and they're going to press the eye or whatever. So that is, I mean, for a preoperative meibomian gland dysfunction, yes, definitely hot fomentation is there. So post-operatively, probably you should give a trial of not a trial, but it's a part of the management itself, doxycycline, and you would you go for some ointments also along with it? And
yes, sir.
for the
we do
what is the preferred
steroid ointment?
Okay.
So we do give an antibiotic steroid ointment, like chloroquine edge.
Any preference for azithromycin ointment or?
So I would like to add that we see many MGD patients. In fact, every person we encounter, they are mostly in the aged group. So they mostly have at least 1 to 2 grade of MGD present preoperatively. So we do like to give ointment azithromycin on the lid margin, as well as there are literature reports showing that azithromycin oral also 1 gram per week on just 1 day for 3 consecutive weeks is much better than as far as compliance also is concerned, as compared to 100 mg BD of doxycycline. So
which has got a lot of gastric irritation issues.
Gastric irritation issues. In fact, I've tried doxy myself. It's very intolerant. So azithromycin, just a single dose, can be given once a week. for 3 weeks. So even that can help in reducing the bacterial load of the lid margin as well as treating the MGDs. So obstructive MGDs especially need to be treated before we undergo subject a patient to cataract surgery. And ointment is definite along with the hot compresses and lid massages.
I mean, a lot of lubricating drops are there.
Yes.
See, is there any we have the Strahalos coming, which says that I mean, theoretically it has this autophagy effect and all. So what would be your preference of lubricating drop? Like, would it be like you finally let the patient choose? I mean, you use one type of a drop. If the patient is happy with it, let him or her continue, or you change it, and ultimately they might say, okay, this is what I'm happy with it. Or is there any definite protocol for you to choose the lubricating drops post-operative?
So I feel that most of the patients do really well on sodium hyaluronate drops. So, and if they're combined with trehalose, or now even vitamin D has started coming inside the drops, so even those can be used. But hyaluronate plus trehalose is a very good combination, or even simple hyaluronate, sodium hyaluronate, because it is a humectant and it has a longer residence time, much more as compared to a CMC. So the patient needs to have more frequent installation of drops. So why not give a drop which is already retains itself for a longer period of time? And now we have preservative free drops also, so we can give sodium hyaluronate. It is the go-to drop for me, at least.
And
I usually prefer a PEG-PG combination. And if the patient is not improving, then I might add sodium hyaluronate. I mean, I don't know, but this has been like, and patients who probably can't afford, or who are like on the milder side, we can just even do a 1% CMC. It works beautifully. So
Can I just make a short comment here? Uh, if our readers remember, our second module of this Dry Eye CliniX was based on this only: what molecule to choose when. And as Dr. Parul highlighted, see, CMC is demulcent only, SPMC is demulcent plus humectant. But when you go to PEG or sodium hyaluronate, they have some epithelial healing factor also properties. So that is what I think the discussion is highlighting. If you are suspecting dry eye post-operatively, where you're expecting some problem with epithelium may be there, and in those cases it's always better to go for sodium hyaluronate or PEG formulations rather than using simple CMC or HPMC.
True, very true. It definitely
very true. Yes.
And
I think that sums up everything.
Yeah, and what is a routine post-operative for cataract surgery and refractive surgery?
Yeah, there's a big discussion. I think, sir, you can start this discussion. Few persons, as I have attended, we had some sort of debate in dry eye under ISCUS. There was this question was there whether to start routinely lubricating drop in all post-op cataract patients, or you should wait and watch the patient. Once the patient complains, then you start lubricating drop. There was completely two different school of thought. So what's your take, sir?
I do give lubricating drops. I don't want to take a chance, because see, it's not, it's sort of a refractive surgery procedure, and you want the patient to be comfortable on the. It's not just the vision. That's what I said. See, the patient with 6/6 will complain. The patient 6/36 might not complain, because he or she has to think of the vision part. So I do give it routinely post-operatively, especially because I do start the patient on NSAID is immediate post-op. So NSAID is whatever said and done, whatever they say, it has that singeing effect. And so I do put the patient on lubricating drops. One bottle, I'll ask the patient to continue putting till it is over. That's it.
So let's take the opinion of other panelists also, because I am expecting another two school of thought here. What is your take, Dr. Gunjan and Dr. Surabhi? Do you routinely give lubricating drops in your post-op cataract patients, or you'll wait till the patient complains?
So, as we all know, actually, post any cataract or refractive or anything, there's going to be some element of surface instability. So we would want to give the tear substitute. And that depends on entirely on the person, how much of surface has been affected, dry eye quotient, how much is it, if you have to go for a CMC or for a PEG tears or for IR. But I think we have to give it. Yeah. And
Dr.
I give
Gunjan?
it routinely.
Yeah. Dr.
Yeah,
Gunjan, what's your take?
yeah. So even I give lubricants to my patient in post-operative period in
Okay.
both the refractive
Dr.
and
Parul, what about your
I give in all
Dr.
patients because there are a lot of
patient?
preservatives, antibiotics, steroids. So we need to wash off those preservatives also. And definitely the lubricants themselves have preservatives, but we need to dilute the effects of the inflammatory side.
I'm left with only one.
And Proful
Dr.
belongs to the
Anu.
other
Dr. Anu,
other group,
are you
right?
on the same school of thought, or you are going to give us a different school of thought? Dr. Anu? I think she's not here. Dr. Anu, are you there?
Yes, sir. Yes, I'm there.
Do you routinely prescribe lubricating drop in your post-op patient?
Yes, sir. I routinely prescribe.
Chalo, in our webinar, we have a single school of thought only. So routinely we do give.
And
Actually, if you haven't given, yeah, somehow the counselor has missed it, or then invariably the patients complain after a week of post-op. Like invariably they do complain that if by chance somebody has not put it. So that is one fact itself. It's like a trial that if you don't give, then patients do complain
There are
definitely.
there is nothing wrong about it. Even if patient
Yes.
doesn't need, still it's not going to cause any harm. So that is but it will benefit a lot of patients. So risk benefit analysis suggests we should give routinely because that will help the patient in any way. Even if dry eye is not there, at times I have seen my resident, they do under block. There are some conjunctival irregularity, surface irregularity. All these problems they can be taken care of in the immediate post-op. So I think we all agree that we should routinely prescribe lubricating drops. Srini sir, continue your
yeah,
question.
I mean, I have a question to all the panelists and the speaker. Like, if the patient has severe dry eye, okay, it's quite severe. Occasionally, the patient has filaments and all, and on treatment, it has and the patient has significant cataract. I mean, he has all the rheumatoid diseases and all. I mean, post-operatively, risk of thinning and all those things are there. So, and the patient requires cataract surgery. When do you actually take up the patient for cataract surgery? And how do you take up the patient for cataract surgery, or you refer to your competitor so that let him or supplement? What? How do you go about it, Dr. Parul, Dr. Gunjan, Dr. Deepa?
So sir, we should optimize the ocular surface first before undergoing subjecting the patient to cataract surgery. So ideally the Shermers and the T-bar should be more than 10, and if it is not, then we send the patient for the systemic evaluation by the internist, and they start for rheumatoid or for Sjogren's, they start methotrexate or hydroxychloroquine. And in fact the systemic drugs only, they affect the ocular surface so much that it is the systemic drugs that stabilize the ocular surface actually in addition to our topical drops and lubricants. So, and still, even after systemic therapy, if the patient is not having Shermers and a good T-but, then we go for punctal plugs or a punctal cautery. So that can also increase the Shermers. Like I had 2 patients of rheumatoid arthritis, and I just did punctal cautery in them, and then did the cataract surgery, and the patient was 6'6". And even in patients of like Steven-Johnson syndrome, we have to stabilize the ocular surface. We cannot let the epithelium break down even during the surgery. So continuous application of HPMC 2% over the cornea during cataract surgery is also a must in these Steven-Johnson patients. And in patients of ocular cicatricial pemphigoid, we if we touch the conjunctiva, they will develop more and more symblepharon. It will flare up the disease. So we have to give systemic immunosuppression to these OCP patients. Like one of my patient was initially on cyclophosphamide, but now is on mycophenolate mofetil regularly. So she was on a maintenance dose of 500 mg mycophenolate mofetil, and only then we operated her cataract surgery, and she's doing perfect. So I think we have to stabilize the surface as well as do a systemic complete treatment, give complete systemic treatment to the patient after before taking up.
So let's consider patients who are not that severe of dry eye with not much of, but it's definitely severe. And where does cyclosporin eye drops stand?
Dr. Deepa, what's your take on this?
I didn't get the question, sir. When is the
Role of
question is,
cyclosporin eye drops?
So cyclosporin, especially the newer ones, formulations like 0.09%, they really work well in rheumatoid arthritis. I've seen patients who were not responding with any pure lubricants. When you add these, they really do well. And along with, as Dr. Parul rightly pointed out, we can add on punctal plugs and punctal cautery. But many of the patients itself, by adding cyclosporin 0.9% and maybe a gel or something like that in the bedtime, it works excellent. And regarding the surgery, one thing I would like to add that the surgery should be taken up at a time when the cataract is not, is not mature, in the sense it is either between grade 2 like that, and the incision should be clear corneal. It should not, there should be no limbal incision. The incision should be clear corneal and at a site where there is no vascularization, preferably if one can do that. And definitely there is many times there are a lot of corneal opacity present in such patients, and I have had the opportunity, and sometimes we have to use the chandelier assisted thing, or a, sometimes we even have to take those, but we have to make sure that you do it or you refer, but there should be not be any intraoperative complication in such patients. And definitely with use of viscoat and high density viscoelastics, the surgery has becomes easier, and it has been this thing, and we have to, minimum trauma surgically, so minimum surgical trauma, and it has to be MICS and with a 2.2 and with an adequate rexis. So each and every step has to be done meticulously, apart from pre-operative and post-operative care.
Just to continue the discussion, sir, Dr. Anu, can you highlight, because today it was a round day and we had all spectrum of patients which Dr. Srini asked. Dr. Anu, could you just briefly summarize what we just saw in the round?
Yes, sir. Actually, we need to balance the efficacy with the risk of delayed healing and other complications also.
So let me just no, actually what I was saying, that we had one patient, sir, with who had a white cataract, okay, but the other eye there is some perforation in the past, and it was a clean looking perforation. So we evaluated the patient, and it was diagnosed as some undiagnosed connective tissue disorder. So we are waiting for the diagnosis to be certain. After that only we are going to operate. So that is one thing. If you suspect any systemic disease association, please be sure what is the disease and then start treatment to that specific disease, and then go ahead with cataract surgery. We have, sir, another young patient, diagnosed case of SJS, and the right eye is phthisis bulbi, left eye is completely keratinized, and there is a white cataract. So in that case, in that patient, even if we know that it's a severe dry eye patient, just to give him some ambulatory vision. So start optimal treatment of dry eye and go ahead with surgery, because we know SJS, no matter what you do, once the keratinization starts, you cannot control the dry eye completely. So the point what I am highlighting is, if you are suspecting any systemic association, first optimize that and then go ahead with surgery. If you know the diagnosis like SJS, OCP, where you don't have a choice, the disease will be there no matter what you do. In those cases, if the cataract is significant, then go ahead with surgery. Third point, which Dr. Deepa highlighted, I think that is a very pertinent point, because we have a very bad experience with one of our patients. The patient had NS1-2. We ignored the surgery, OCP patient. Then the patient went outside and got operated from some distant hospital, and then she was left aphakic with vitreous. Now the patient is a big problem for us to manage because the dry eye is severe, sees phakic, there is vitreous in interchamber. So it's always good to take a call early if your dry eye disease is controlled and you know that cataract has started. For me, it's better to go ahead with the operate rather than waiting. It becomes advanced stage and you struggle with the surgery.
So we've talked about all this. See, in these patients with dry eye, when you're taking up them up for cataract surgery, see, basically, I mean, almost everyone does under topical anesthesia only. Very rarely do give blogs and all. See, the drops that we use preoperatively, the ones like povidone and proparacaine. See, what role do they have to play in the postoperative ocular surface issues? And do you modify? I don't know how to modify whatever, because you have to use povidone, you have to use povidone, you have to use proparacaine, you have to use proparacaine. So, is there any way in which you can actually reduce the toxicity or whatever from? Is there any particular protocol that you have?
They know not more than 2 drops of paracaine should be put. So that's what they say.
And
like, not
one
be
thing, without any financial interest, you can go for intracameral anesthesia.
No, the problem with the phenocaine, absolutely no financial interest. Also, it works, but the issue is with the surface anesthesia. It's not the iris. It is not the iris as such. It is the proparacaine that is actually helping. Putting the speculum, putting the incision and all. So you need surface anesthesia. So probably you have to minimize the use of
yes, only twice, just before surgery.
Yeah,
and then once.
Yeah. So that's the thing. And do you give NSAID eye drops preoperatively? So that's another question. Like it's supposed to maintain the
even the
pupillary
retina
dilatation.
specialists, they say that it doesn't play much of a role in preventing CME. So especially in patients who have such risk factors, I think it should be best avoided to use any kind of NSAIDs pre or post-op. Maybe if later on it develops CME, then it can be treated as it is. But I think if it is an uncomplicated, uneventful surgery, then it is a very rare chance that patient will develop.
But
so
now
if the patient has dry eye, you won't start NSAIDs postoperatively. Dr. Parul?
Not as a routine.
So we have drugs, NSAIDs, which are preservative free and which need to be put only once. So we can use those NSAIDs. So no financial interest, but Amplinac is one of them. It can be given OD and it's preservative free. So that can be, I think, safely used in these dry eye patients. If we suspect that if patient is a diabetic or complicated cataract surgery has occurred, so we can always give Amplinac OD post-operatively. And regarding the proparacaine, we need to give it twice. Once it is outside, the patient is outside the theater, and once inside. And then I like to put the HPMC 2% gel over the cornea. So that is also cold, and that also reduces the pain sensations. And so we don't need to put the proparacaine after the initial few steps actually, because we are injecting the intracameral anesthetics agents also. So those will act inside the eye, but the proparacaine has done its effect initially, and we've placed the cold HPMC 2% over the cornea. So that will also decrease the dryness and the repeated washings which are required, which increase the evaporation and the further dry eye. So I think HPMC 2% over the cornea is a very good thing to do.
Perfect. See, coming back to the question of cyclosporin eye drop. A patient developing dry eye postoperatively, when do you start cyclosporin eye drops, and how long would you continue using this?
So I
Sir,
would
if a refractive surgery for patient presents with a dry eye, like after we have given 1 or 2 months of lubricating eye drops, he still complains. Then we usually add cyclosporin, and at least for 3 months. And I have seen that patients, they do come, like when they come after 2-3 months, they're much better. Either if it's a natural course or if it is due to cyclosporin, that's still maybe a question, but yes, it has definitely helped them in, recovering naturally, and at least symptomatically, they say that they are better after adding the drop.
I totally agree with you. Like
Cyclosporin.
the cyclosporin drops do really help, and the Indian ones that have come, they absolutely effective. I mean, I'm not taking the names of those that comes
Yes,
in
sir.
the
Yes,
unims
sir,
and
they
all.
have. Yes, sir. So
Yeah,
the recently, no financial interest, but yes, this Sequa which has come up
yeah, exactly.
recently, 0.9%, it has helped in dry eyes at least. Although they claim that it is effective in VKC and stuff like that, but we have
VKC
not.
needs 2% and
Yeah,
all, and you
VKC
get
needs
it
all
from
that.
oral app.
Yes, but at least in post-operative dry eye, because we tend to see a lot of refractive surgery patients which come back, and then if you add, then it does make a difference.
So you can add cyclosporin 0.09%. Don't
Yes.
remember the name because our
Maybe.
sponsor is somebody else for this webinar.
Yeah.
Yeah. Any of the
Yeah,
0.9.
Any of the
of the
0.09%
cyclosporin drops, but
cyclosporin drop.
those which those that come in unims do work quite well. Whoever comes with that, I mean, anyway, it's quite okay.
Okay,
Dr.
there are some questions from the audiences.
I also,
One is, yeah, Dr. Anu, please continue.
um, there's a question, how do you assess and manage post-operative neurotrophic keratopathy? That is complicated by dry eye, particularly after corneal surgeries. Like the challenges in treating both the reduced corneal sensation and associated dry eyes.
Dr. Parul?
Dr. Deepa. No one is here.
give post-op lubrication and then intensive lubrication depends on the stage of neurotrophic keratitis. It can be stage 1, stage 2, or stage 3. Stage 1 can be just the punctate epithelial erosions which are there. So they can be managed by the topical and lubricating ointments. And stage 2 is a stage of epithelial defect, and stage 3 is the severe ulcer or the melt which takes place. So we can use these lubricating drops. We can use cyclosporin. There is lifitegrast also which has come, so that can be used. That also helps in, it is anti-inflammatory and ICAM inhibitor, and that also decreases the inflammation as well as the sensations. And then there is senagermin, that is oxervate, which is not there in India actually, but it is given at a 2 hourly dosage, that is 6 times a day for 8 weeks. So it was
So
USFDA.
we'll have a different lecture on this neurotrophic keratitis for the audience. So for the time being, you can remember the treatment of neurotrophic keratitis is same. Even if it is after dry eye, the management doesn't change.
Same.
I
Yes.
think I am right, Dr. Deepa?
Have done. There is staining is positive, just add them 1 hourly. So 2 days it becomes better. Like after 2 days it becomes the staining goes away at least.
Dr. Anu, any more questions? There is one from, I think Sarika has put it. Actually, I think you have already covered it in a PPT, but the audience question is, what is the cause for watering from eye after cataract surgery? Many times patient complained about watering from eye after cataract surgery. What is the cause?
Dr. Deepa, you can take it.
So it can be reflex watering after, reflex hyperlacrimation also, like, due to dryness, there can be reflex hyper secretions of tears. So even that can present as, lacrimation. That can present as watering for the patients.
See, I mean, because this question has been raised, like you said, the commonest symptom that patient comes if the patient has dry eye is photophobia. for me, very rarely patient has complained of photophobia. That it's basically watering, foreign body sensation and all. So that answers the question of why patient complains of watering. So it's basically the dry eye that is leading to watering.
And even the preservatives in the medicines, they also cause irritation and increase the watering, reflex tearing, basically.
Yeah. Anything more, Praful?
There is one more question about giving lubricating drops in post-op cataract. So now there are patients who doesn't put steroid. Rather, they keep on putting lubricating eye drops. If you give lubricating drops, so that is the question from a student. So should we routinely give it because the patient may stop using steroid antibiotic and keep on putting lubricating eye drops?
That's basically improper counseling.
But RP center, sir, you must have, you must remember, that's why earlier days, we used to give Exopred because that has everything. So that the patient is not getting confused.
Yeah.
Same in GNEC, like we used to give Exopred and that's all. And homemade.
Of me, chairman.
Praful, it has been a wonderful talk by Dr. Deepa. Parul discussed really well, and you, as usual.
I think breaking in between, so I'm not able to connect.
Yeah, I mean, I said it's been it was a wonderful presentation by Dr. Deepa, and Dr. Parul, as usual. She has answers for everything, and even you have answers for everything. So, is there anything more to discuss in it? We really understood the preference of the lubricating drops. We have seen that meibomian gland dysfunction has to be managed, and Dr. Paul's preference is basically azithromycin orally and not doxycycline, and cyclosporin is quite effective, and you have to look out for dry eye postoperatively in both post-cataract and post-refractive surgery. So that's
Can I ask a question if it's time permits?
Please.
1 minute. You have one more minute, Dr. Saurabh.
I have 1 minute. Okay. How many days after a surgery would you advise for hot compress? How long do generally everyone wait? Because usually the patients do complain immediately also, but we don't start it immediately because the patient obviously has just undergone a surgery. But how many days gap does it?
See, I would wait minimum 2 weeks. I mean, at least 4 weeks, because you don't know what they're going to do. So 4 weeks is see, that is the reason why I would go for oral whatever, doxycycline or azithromycin, because I don't want to be over aggressive or whatever. I mean, so that's Praful. What about you?
Hot compression. I will wait for at least 4 weeks because I know I have one bad experience about that. Post-op cataract surgery, we advised hot compression, and that patient came back with lid burns. So it's better to
exactly like you ask for cold compress for allergic conjunctivitis, they might put eyes on top of the lids and they come with.
It's better to avoid. Yeah, you can wait.
Yeah.
Wait.
Okay, so I think it's time to conclude here. Dr. Anu, before you conclude, just to update, sir, this is a continuous series of both for the new speaker and chairperson. So we are doing a 8 webinar series, and we started with etiology, then we went out to diagnostic, then we had a session on type of lubricating, what are the composition. And now we are covering specific topics like post cataract surgery. Then we'll have something on post refractive. So this is how we are going, sir, Dr. Sini.
And
So
it's going to be there on the website of
yes, sir.
DOS.
Once this is done, we'll publish an archive in DOS YouTube channel where all the lectures will be there compiled. All the 8 modules will be compiled, and Cipla Pharmaceutical is helping us in conducting this webinar. So thank you, Cipla people. And surprisingly, in contrast to other webinar, this webinar is a huge hit for us. Today also, I think at around 8 we had 273 live attendees, which for me is a good number considering the attendance nowadays in webinars. So thank you, Cipla. Thank you, attendees. And Dr. Anu, please conclude.
Yeah, I would like to extend warm thanks to Dr. Deepa Gupta and Dr. Srini sir for sharing their expertise and taking time to join us today. And thanks to all the panelists and discussants for sharing their experiences. I would really like to thank all the attendees for joining us today.
Yeah, thank you, Dr. Anu and Dr. Praful. It was an excellent being here, excellent experience, and everybody, Dr. Srini, so much to learn from everyone. So thanks a lot for inviting me. Yeah.
Thanks a lot. Thanks a lot. Thanks a lot, Praful, and Deepa, everyone. Thank you.
Thank you, Dr. Praful, Dr. Srini, Dr. Anu, all of you. You did a wonderful job.
Bye. Bye. Good night.
Thank you. Bye.